Okay, thank you for that wonderful introduction. I am Dr. Kunal Parekh, a nephrologist here in private practice in Honolulu. I was initially asked to give this talk today about the role of kidney disease in the aging population, but I felt that most likely people will benefit from getting an understanding about some of the terminology, understanding some of the nuances, and kind of helping differentiate between the different specialties that are out there. And then later on, talking about the most common forms of kidney disease, and then what are some of the treatment modalities and things that we can do to prevent kidney failure. So I'll kind of jump right in. So this is a little bit of today's outline. I'll talk first of all, what is nephrology, then jump into kidney function. I'll introduce the concept of the glomerular filtration rate. Then we'll delve deeper into the functional unit of the kidney, which is the nephron. And then the big topic, which is chronic kidney disease. Then I want to talk a little bit about specific terms such as biomarkers and how to estimate the glomerular filtration rate, because this is something that if you ever have to contend with kidney disease, some terms familiarity will kind of go a long way for you. And then additionally, we'll then talk about the general management, the broad overview management of most forms of chronic kidney disease, and then talk specifically about the most common forms of kidney disease, which is going to be diabetic or high blood pressure related kidney changes. And then what we're really interested in is also to talk about prevention. So, first and foremost, a lot of times I think most people have never heard of a nephrologist until you kind of need one. And so nephrology really is the subspecialty of internal medicine that focuses on the diagnosis and treatment of kidney disease. And the kidney really is a remarkable, wonderful organ. It's so complex, and in a way, it's so beautiful because it does so many critical functions that it's really hard to pinpoint what it exactly does. And we'll kind of go over into that, but nephrologists are the doctors that maintain the expertise in primary kidney disease and also how to manage them. They help prevent, identify, and manage early disease just as well as internal medicine doctors can do. But once these diseases become more complex or more advanced, then nephrologists can jump in. You have to have a 3-year internal medicine residency followed by fellowship training, specialized super specialty training in nephrology. And then there is a board certification which is offered by the American Board of Internal Medicine. So when patients or people first meet me, a lot of times they have the question about, well, wait, what kind of doctor are you? Did you say neurology, urology, nephrology? So a lot of these kind of sound the same. So we have 2 doctors on the same system, and it can become a little bit confusing for people initially. So we have, for example, nephrologists, that's what I am, I'm a medical doctor, and then you also have urologists, which is a surgical doctor of the same system, of the same kidneys, ureter, and bladder system. So one's a medical doctor, one is a surgical doctor. And what I like to do is give some examples to help highlight the differences on when you might need which one. So the first example really is, imagine somebody has a kidney stone. So if they have a stone, well, the urology doctor will be the one to kind of go in and help get that stone out. But the nephrologist, the medical doctor, will be the one to help decide, well, how come this patient formed the stone in the first place? What kind of stone is it? What can we do to prevent further stones? Or how can we prevent the existing stones from getting bigger? So these are all medical questions that a medical nephrologist will help decide. Another example would be, imagine someone has, let's say, cancer of the kidney. Well, the urologist can go in there and maybe cut the kidney out or cut the cancer out. But the medical doctor, the nephrologist, will be the one to help manage that loss of kidney function that follows cutting part of that kidney out. So now you have somebody who has less kidney function. Well, what are some of the ramifications of that? How do we manage the medications? That kind of stuff is what nephrologists do. Going forward, suppose the patient has then really bad kidney failure after the surgery. Maybe they need to go on dialysis. So nephrologists are the doctors that prescribe dialysis. And suppose that patient later on goes on to get a kidney transplant. Then nephrologists are the doctors who will manage that kidney transplant, the immunosuppression, prevent rejection, and help guide that allograft or that transplant function for its life. So having kind of looked at the different specialties, before we can understand disease, we really must get an understanding of what is it that the kidneys actually do. Why do we have kidneys? What do the kidneys do? Where are they located? And how do the kidneys do their function? And, if we ask 10 different people, we all kind of know, oh, we have kidneys. But what is it, a scientific answer? Or if we ask 10 different people, tell us, what do the kidneys do? We're probably going to get 10 different answers. But I think at the end of it all, we can agree that kidneys are responsible for removing waste products from the body, right? They also help remove drugs from the body that we take, the medications and all of that. Helps balance the body's fluids, and that includes balancing the person's water, solutes, acid base. They also play a key role in the regulation of hormones and blood pressure. And then also kidneys produce an active form of vitamin D, so it has a role to play in mineral and skeletal health. And also it helps control the production of red blood cells, so it has a role to play in anemia as well. So that's quite a tall list for people to kind of spout off that's what the kidneys really do. The way I like to exemplify what the kidneys do is in one sentence, it's kidneys are responsible for maintaining the environment of our body in a normal condition so that all of our other organs can function normally. And I kind of sometimes make a joke or sometimes talk about how, imagine if the body had, environmental services or the janitorial system, right? If you don't take care of our city streets and garbage piles up, then really we wouldn't be able to move around and do the things we wanted in society. And that's kind of the same thing that kidneys do. They help eliminate some of the waste and also keep the environment of the body in a normal range so that the other organs can function properly. And some of those same things that I mentioned about removing waste products from the body, removing drugs, balancing all of the fluids and the electrolytes and the acid base, right? Releasing different types of hormones. So all of that is it's different parts of the functioning of the kidney. But if you were to, let's say, just go in and try to measure how well does the kidney get rid of waste, or how well does the kidney take care of anemia, or how well does the kidney produce vitamin D, or how well does the kidney regulate blood pressure? These are all kind of separate and difficult to bring under one umbrella. And so that's why there's this concept of something called the glomerular filtration rate. I'll kind of explain what that is, but this is, in a nutshell, the amount of blood the kidneys process every minute to maintain that normal body environment. And so often, if you ever look at your lab reports, you'll see that there is something called the eGFR. That GFR that's there stands for glomerular filtration rate. And the E just means that it's estimated, that we didn't go in and put any catheters or plastic tubes and we didn't measure it, but we estimated it. And so this is what your lab report really talks about, is this glomerular filtration rate. And because it's talking about how much blood is processed per minute, it's expressed in milliliters per minute. And because then we will take this milliliters per minute and then we adjust it for individual body size. But if we are not adjusting it for your particular individual body size, then it's then expressed as over 1.73 meters squared, which is the standard. So this glomerular filtration rate really comes from this graphic here that you see. This is, you can see the ultrastructure of the kidney magnified here. You have this part here, which is called the cortex, and these parts here called the medulla or the pyramids. And when you zoom in, this is where all of the work really happens inside the kidney. Blood comes into the kidney, and blood exits the kidney through the blue vessels. But at some point, you have to have this interface where there's blood, and then ultimately that blood is somehow transferred into urine. And that's really where this occurs, is inside the glomerulus, where you see all of these little blood vessels inside over here. And around it is this tubule, which kind of catches the urine that is produced. And so this structure is called the glomerulus. So anything that's filtered out of here is called the glomerular filtrate or the filtrate. Ultimately, that urine or that substance initially goes down the different tubules. It'll make its way, and along these tubules where you have specialized cells, and they will fine-tune the urine composition till ultimately it goes down to bigger and bigger tubules, and then it actually is called urine. So suppose, for example, I have been running a marathon, or I have been working out, and I haven't been drinking enough water. Well, initially, you're going to have some filtrate that's being produced from the glomerulus into the tubule right here. But as it makes its way down, the tubular cells are smart enough to recognize that, hey, this person, is dehydrated. Let's suck some of that water back out. And so it will fine-tune the urine to whatever is going on in the subject or the animal's life. What's interesting is that on average, we're born with about 1 million of these nephrons per kidney. So that's about, on average, 2 million nephrons per adult. And this is where now, once we understand the ultrastructure of the kidney, we can start to understand a little bit about kidney injury. Because injury of any sort, suppose you have a penetrating injury like a bullet, or you have kidney stones, or you have chronic infections, or you have diabetes, or you have high blood pressure. Ultimately, it results in injury to one or multiple parts of this structure. So you can have injury to the blood vessels, such as vasculitis. You can have injury to the glomerulus. You can have injury to the kidney tubular cells, right? You can have injury to the background cells that line it. And whenever you have any type of injury, as we age, and depending on the severity of that injury, over time, you're going to start having scarring. And so when you have scarring, you start losing function from that particular nephron. So when you lose that nephron, you lose that one functional unit. So we're born with those 2 million nephrons, and once you had that injury, however large and severe that injury was, you lost those nephrons. And that's how you get lower or decreased kidney function. What's also incredible is that kidneys have a remarkable capacity to maintain their function and can actually compensate. So it's a beautiful organ. It's so elegant. It's wonderful. That if you do have, for example, one nephron goes down, the surrounding nephrons around it will actually do more work to maintain the function of the kidney. And that's really fantastic. And that's why, it's so resilient that it can withstand different types of injury, even episodic injury that comes and goes. And while that is really good, it's also its downfall. And, I kind of liken it to, this picture here where you have all these highway, lanes. And think of it this way, that, all of these lanes are open for traffic, and traffic is freely flowing down. Imagine what happens, let's say you have an accident that takes over these last 3 or 4 lanes. What's going to happen to all of the traffic? it's going to now have to go onto these other lanes that are still open. So you're going to get more congestion in the open lanes to compensate for the loss of lanes over here. Well, it's the same concept that happens in kidney disease over time, that if you have damage, let's say you have diabetes, and that diabetes is causing kidney damage, then as you get that one single nephron gets damaged, the other surrounding kidney tubules and nephrons are also experiencing the same damage. But because you lost that one nephron, now you're 1/99999 doing more work. And then the second nephron goes down. So by percentage, eventually you start getting more and more kidney damage. So while it is a wonderful strength of the kidney for resilience, it's also its downward downfall. And you can see this downward spiral. Once a chronic, slow kidney damage sets in, it slowly is a downward spiral. So we kind of now understand the mechanism of kidney disease and loss of nephrons. So we call that chronic kidney disease, right? When you have a loss of nephrons, you have a loss of glomerular filtration rate. And the way we define chronic kidney disease is that it has to have signs of kidney damage for at least 3 months. So you have low GFR, and that can also be present as blood in the urine or protein in the urine. Or let's say somebody has a very large cyst. Imagine somebody has a polycystic kidney. Well, that person has the loss of a normal architecture, so their functioning isn't normal. Or if someone, let's say, had a trauma, a motor vehicle accident, and we had to take part of the kidney out. Well, they're missing some of it, right? So while the remaining kidney may be normal, but they have lost function. So it's chronic kidney disease is anything that causes kidney damage, and that's going on for at least 3 months. And when you look at, especially in the United States, what are the things that cause kidney disease or chronic kidney disease? Nearly 75% of it is due to either diabetes or high blood pressure, as you can see. The rest of the stuff is quite, others and smaller, but the bulk of it comes from diabetic kidney disease and high blood pressure. Right? Diabetes happens when your blood sugar is too high, causing damage to many organs, including the kidneys, and then high blood pressure is equally damaging to the kidneys, because high blood pressure, kidneys get, and one way of thinking about it is that kidneys get about 25% of the output of the heart. So when you have a tremendous amount of pressure, they're sustaining that, or they're withstanding that pressure that's being delivered to them. There are a lot of other conditions that affect the kidneys. Otherwise, we wouldn't be here today. So, for example, there's glomerular nephritis. That happens when you have that glomerular structure that I mentioned earlier, where all the filtration takes place. You can have inherited diseases such as polycystic kidneys. You can have malformations that occur, when the baby is developing in its mother's womb. You can have autoimmune problems such as lupus and other disorders. You can have physical and obstructive problems such as kidney stones, kidney tumors, right? Prostate enlargement is a big one that we see, where urine is not able to exit the body properly. And then repeated urinary infections is something that we see as well. Every time you have an infection high up in the kidney, it's a wave of inflammation where your white blood cells are activated, and there's a war going on between the pathogen or the bacteria and your immune system. And eventually, it's the lay of the land, the architecture is going to get ruined over time. And there's many, many, many others. Another important concept to think about is that as we age, our bodies also age. And, after the age of 40, depending on which textbook you read, an estimated 7 to 10 ml per minute is lost per every decade of life. And some more recent reports estimate that in the United States, we lose GFR 1 ml per minute per year of life. So this is an important concept, that when you're an older adult, your kidney function is not expected to be 100%. The organ has aged with us, and it will have a lowered function. So older adults are expected to have a lower function. Now, some authors would obviously argue that just because you're older and you have lost function and there's changes consistent with normal aging, that's not necessarily disease. And others would argue, well, decreased function is disease. So that's kind of some debate, but when you look at your age, you can calculate what is your expected GFR based off of these formulas. Chronic kidney disease has different stages. So if you've ever looked at your lab reports and you look at that GFR value, it'll tell you what the estimated glomerular filtration rate is. And the higher your GFR value, the better your stage of chronic kidney disease. So there's about 5 stages, and you can see that stage 1 is practically 90 to 100% normal functioning. Stage 2 is when it goes from 89 to 60. You don't have to memorize this. This is just for illustration, but as the stage numbers continue to increase, you can see that the kidney functioning decreases down to where stage 5 is considered the most severe form, where you actually have kidney failure. It's less than 15% kidney functioning. And so this is why it's important to pay attention to the lab reports that you get so that you can track where your kidney function is along the different years and span of your life. I'll talk a little bit about now how this GFR is estimated. So there is such a thing as being invasive and then trying to actually measure someone's GFR, and that's an invasive procedure. And so what we do instead is that we estimate people's GFR using a formula. And those formulas are fairly accurate estimates, and then that's why you see that eGFR on your lab test. And because of that property of the kidney, which has the ability to maintain function for a long period of time, oftentimes you don't feel anything until you're down pretty low into stage 4 or stage 5 criteria. And so the first thing that's important is vigilance and looking for it. Because if we're not looking for it, we can't identify it. And if we can't identify it, then we can't enact measures to slow it down. So when you look at lab results, right, these are the typical lab results that you would see on your last lab report. And you might see, for example, the chemistries, they'll talk about sodium, potassium, chloride, bicarbonate, the urea nitrogen or BUN, the creatinine level, glucose, calcium, and then this eGFR. And this is the one that I was talking about where, you know, a normal would be, depending on your age, what the expected is. However, if you look at the lab results from last year to what you're going to see in 2022 going forward, is that the use of race in eGFR in estimation has been reevaluated. As of everything that's going on in the world and in the political climate, medicine is no different. And so we are now removing race from medicine to prevent some of the inequities and to improve healthcare outcomes. So because that happened, if you look at the lab results from last year, you'll have these race variables, but no more in 2022. The original equations were redeveloped and the data sets were reformulated. And so you actually have now more accuracy going forward. But what that also means is that if you look at your lab result from December 2021 or perhaps June 2021, you might have one value of the eGFR, and then you look at it again in January 2022 going forward, you'll have a different result. And it may just be because during that transition period, the lab started using a different formula. What's important is to overall look at the global trend. Overall, are the numbers slowing down? Are they staying the same? Or are they even improving? So some of the common equations, you know, there's not only one equation. In medicine, we have different equations that we use to estimate people's GFR or kidney function. And so the most common ones that are in use today, and you can go online if you're inclined to get your lab results, get your blood creatinine levels, get your blood cystatin C levels, and you can find these equations, plug in your values, and using the different equations, it can give you what the different estimations are using different equations. They offer varying degrees of accuracy, but overall, some of the best accuracy comes from the use of the CKD-EPI creatinine and cystatin C equation. So sometimes you may see that kidney specialist or your doctor may order a test called a cystatin C or a creatinine to try to estimate your kidney function. What's also another concept or something interesting to pay attention to is that there is this very nice relationship between the creatinine level in your blood, which was one of those lab tests that I showed you earlier, and the GFR. So the equations will plug in these creatinine values, your age, your gender, and then give you an estimate. And the idea is that as the creatinine level in the blood gets worse, the GFR has been dropping steadily. And when you go from a creatinine of, let's say, 0.5 to 1.0, the loss in GFR is much greater compared to, let's say, if you go from 2 to 2.5, the actual loss is much lower. So that's something to keep in mind as well. But why is it important to recognize chronic kidney disease? Well, because we also know from other studies that those who have chronic kidney disease have an increased risk of cardiovascular disease. And this can be explained in part by having high blood pressure, diabetes, and the metabolic syndrome. But in and of itself, chronic kidney disease is an independent risk factor for cardiovascular disease. In fact, chronic kidney disease is considered a coronary equivalent. And once you have chronic kidney disease, you have to have close attention being paid to preventing and managing cardiovascular disease. So that's an important point there. And also, additionally, once you have chronic kidney disease, then obviously you are at higher risk for the slippery slope and developing end-stage kidney disease, where you might need a kidney transplant or dialysis. So all of that is kind of scary, but there are some tools that we have to manage chronic kidney disease. So the first thing is to find out, well, what's causing the kidney disease? Is it something that's reversible? Is it some medication that's there that perhaps we can take it off and either put something else on or switch it out? Or is the patient's blood pressure out of control? So those are some strategies that you can take a look at. What complications of kidney disease do they already have? Do they have problems with swelling? Do they have problems with electrolytes, acid-base problems, mineral bone disease, anemia, skeletal health? So all of those things that we start taking a look at. Also, some of the other general management, once you have chronic kidney disease, you have to go back and kind of reevaluate the medications that you're taking. Different drugs are excreted out through the kidneys. So the drug dosing has to be adjusted for your kidney function. And then over time, as you see that, build that chart of seeing where your GFR is, and suppose that it is dropping over time, then we have the time when you might need any form of what we call renal replacement therapy, some form of dialysis or kidney transplant, so that you don't suffer any ill consequences. Eventually, along the way, you may need a referral to a nephrologist. So this slide kind of talks about what are some reversible causes of kidney failure. Well, some of the common reversible causes is low blood supply. So for example, if you just have low blood volume, if you're not hydrating well enough, then you're not delivering enough blood to the kidneys, and that can cause damage. Low blood pressure, such as heart failure, liver failure, those things can also cause kidney failure. Infections, right? If you have severe infections, your immune system is activated, your pressure is low. So if you treat those underlying causes, then the kidney function may be able to withstand and come back to its former glory. Suppose that someone is on toxic drugs, for example, ibuprofen, indomethacin, celecoxib, meloxicam, naproxen. All of these medications are great for controlling pain, but in the long run, they can also affect your kidneys. And oftentimes I see that in my practice where patients are unwillingly or unwittingly taking these medications, and just removing this medicine, you can see their kidney function may come up a little bit. So be wary about taking these medications for a long period of time or long term. This is not for everybody that we should just stop these medications, because you have to look at that individual in front of you. So if someone's quality of life is terrible, then perhaps, living in pain is not an option and you have to treat them. But also know that it comes with a cost. Different type of toxic drugs, such as contrast media, such as the CT scans and those kinds of things. When you go for a coronary angiogram of your heart, that contrast eventually swims around to your kidney and causes damage. So recognizing that these different agents can cause problems, you can then avoid them and find strategies to mitigate. Different antibiotics can be toxic. There's different agents that are toxic. And also obstruction, right? If you have stones, strictures, prostate disease. So those are the things that, are potentially reversible. So blood pressure control is one of those things that, we've seen that more intensive blood pressure lowering actually reduces the risk of end-stage kidney disease in those who have chronic kidney disease, and especially those who lose protein in the urine. So talk to your doctors about, what is the right blood pressure for you and if you're on the right regimen. Also, when you have chronic kidney disease, our focus will be then to find out, well, why do you have chronic kidney disease? What are the underlying causes? And then trying to treat those and address those. But we use specific drugs such as ACE inhibitors or angiotensin receptor blockers quite a bit. We'll use these medications called SGLT2 inhibitors, which actually have been shown to have benefit in diabetic kidney disease, but also those who spill protein in the urine. There's other targets for kidney protection, such as restricting protein, if someone is smoking, to get them to quit that habit, treating high acid levels in the blood, controlling their blood sugars. So these are some generic things that pretty much we can try to help slow down the rate of chronic kidney disease progression. But some things that you can do immediately now would be to stop smoking if you're smoking, check your blood pressures, maintain a healthy weight, and exercise, right? It's nothing that you haven't heard about or thought about. It's things that we all know, but these are the things that we can try. There are some complications of chronic kidney disease. For example, patients can have fluid overload, swelling, high potassium levels in the blood, too much acid, low blood counts, cholesterol problems. So all of these things are things that we would help assist and manage as the disease progresses. This is really important, especially in today's day and age where we're faced with a global pandemic. People who have chronic kidney disease, as I mentioned earlier, not only are they at higher risk for cardiovascular complications, but they're also known to have decreased immunity. And so they're at increased risk for infections, especially lung, like pneumonias and genitourinary infections. So particularly now, if you are not vaccinated against COVID-19, I highly recommend you start your vaccination series. And the progression goes that if you have injury, ultimately, if it's not reversible and if it's progressive, it goes to chronic kidney disease and eventually to end-stage kidney disease. This is not the last chapter, but it's the beginning of the final chapter of your kidney disease. So once you have progressed to end-stage kidney disease, your options for treatment are quite varied, and it depends on you as an individual person. But for example, you can do some different types of dialysis. You can talk about transplants. We also can do, medical management or just conservative management as well. So there are different options, and it's not the final or end chapter. So in general, this is kind of one of the main contributors to chronic kidney disease in the United States. I've listed here some of the things that we would target for you, and some medications that have been shown to slow down kidney disease. So this is why it's important to be mindful of what your GFR is. How is the GFR trending? Do you have any panic values or high-risk features that would suggest that you're going to progress, and what are some of the medications that you can try? These are some questions that I've listed here for you so that it starts you on your journey if you do have diabetes to prevent and slow down, or at least start if you're not aware that you have chronic kidney disease, to start looking and take the right steps. Same thing with high blood pressure. These are some of the strategies that we can employ. Medications and ruling out secondary causes is something important that if we can fix and find, then maybe we can reverse the cause of the high blood pressure. But again, here are some questions for you to take a look at what you can do and to start your journey to prevent kidney failure. And this saying, right, an ounce of prevention is worth a pound of cure. That goes, 100%, which is maintain a healthy weight, eat a balanced, healthy diet recommended by your physician, exercise regularly, seek preventive care. Right? It's too late in the game if you're really seeing me or another nephrologist, right? You never want to get to that point. So preventive care is where the real action is. And that starts with getting annual checkups, getting labs, paying attention to your health, and being involved. And if you don't understand something, ask your provider. And that's how we start. Cut back on bad habits. And remember, drink plenty of water, because about 55 to 60% of your body is composed of water. Okay, thank you for your attention. These are some useful links that I think would help you on your journey. But if you have any questions, I'm happy to help you.